January, I'd like to ask you a question just to get started here. We know that every state is unique, and you could see from this data that there are some similarities, but also some differences across the states. Could you just say a little bit from the Bailit Health perspective? You've worked with all of these states as the technical assistance contractor for this program, and also through individual arrangements you have with other states. What do states with these programs have to learn from each other? What is some of the value of some of this, if not quite standardization, consistency, some level of consistency in terms of how states are looking at these issues? What can they learn from each other?
Sure. So it is true that each state is unique, and this saying that you often hear in Medicaid that there are really 50 different Medicaid programs kind of applies to spending growth target programs as well, where you have this broad framework that lays out the key components of the program, but the details of how each of those components are implemented in a state can vary. But just because they're different doesn't mean they can't learn from each other. And across these states, there's a lot of cross-pollination of ideas around how to approach particular issues, like how to think about the governance structure or what accountability mechanisms might make sense and how to implement them. I would say more than standardization, from my perspective, some of the most valuable conversations that come out of those conversations have been around how states are engaging and partnering with stakeholders in their respective states on how to address rising costs. In the end, these states, they all share the same goals, right? What they're trying to do, the reason that they set up these cost growth target programs is to do something around affordability. And so hearing from each other around what strategies they are trying and why, what strategies worked well or didn't work well, and how these conversations are going with the stakeholders that they're trying to partner with, I think that's where the greatest value is in terms of the sharing of information and sharing of lessons learned.
Sarah, we had a question in the Q&A here about a recent healthcare access amendment to the Oregon State Constitution, and has that had an impact on your advisory committee's discussions about access and affordability? Perhaps you could explain the amendment briefly and then answer that question.
Yeah, this is dangerous. So there was a recent, there has been a long time legislative effort to pass a constitutional amendment in Oregon that would guarantee healthcare access for all. That recently happened, and I think I want to say the short answer is yes, this is impacting conversations, and there are conversations, but also it's not immediate yet. I think there are a lot of things that have to happen in terms of interpretation of this. I think access can mean a lot of different things, and depending on how the amendment is interpreted, does that mean that should it be interpreted as an insurance coverage for all? Everyone in the state needs to be enrolled in insurance somewhere, or does it mean everyone should have access to care, as in you can go to a doctor? And there are lots of implications, and there's been a lot of think tank thinking about that. And so I think absolutely there is an impact on cost at some point. We have not yet started talking about it directly as part of the cost growth target program because it's not sort of landed on how it will go. But I will say that as part of our cost growth target program, we have, and we're working to solidify what we call our good reasons for cost growth. So as I said in my slides, not all cost growth is bad. We know that there are certain things that we want to make sure happen. We do not want any payers or providers or state policies, any attempt to help us meet the cost growth target to result in people losing access to care or other stinting or other measures that might cause harm. So we have a lot of places where we're looking for that, we're monitoring for that, and we're making sure we have sort of a checks and balances on if there are state changes in state law or federal law that affect costs, that we're taking that into consideration before we go hold any payer or provider accountable for failing to meet the target. So for example, if our state, as they do, passes a new insurance mandate and says you must cover this new service, that of course will have an impact on healthcare costs because it's now a new covered service. So that's something that as we review the cost growth each year, we'll understand how that plays out. And if the reason, say, a health plan exceeded the target was because they were covering this new mandated benefit, there would not be any accountability or penalty for that. So in a lot of ways, this amendment is, would fit right into that. We have mechanisms built in our program that create flexibility so that when there are these changes in policy or unforeseen circumstances like pandemics, we can be flexible and adapt.
Thank you. Deidre, I think you wanted to come back for a moment to the insurance commissioner authority question.
Yes, and before I do, I will just add that Connecticut also has two of the provisions that Sarah referenced. One about monitoring any adverse impact. Although I have to say that when you have 50% of commercially covered individuals who are foregoing care because of costs, that's already an extremely adverse impact. So it's going to maybe swamp other impacts related to the costs coming down, but we do have that as part of our statute. And we also have the ability to do a review. And in fact, that was also put into the legislation for things like inflation and other unforeseen circumstances.